Government, civil society and policymakers gathered for the 8th South Africa TB conference. It was part of ongoing efforts to curb new infections and deaths. Now, South Africa is one of the highest TB infection rates in the world, according to a report by the National Institute for Communicable Diseases. Let's talk about this now with Professor Norbet Njeka, who is the head of the TB program in the Health Department. Prof Njeka, thank you very much for your time this morning. This was a grave discussion that you had, and you had a number of experts in the room, scientists, researchers, academics, government officials, but importantly, you also had civil society there. It's a big issue that we continue to face. 148 people dying each day in South Africa, and it's likened to an average-sized plane crashing with all on board and dying every day. So the situation is quite dire, and I'd love for you to just talk to us a bit more about the profile of TB in South Africa.
Yeah, thank you so much, and thank you to all the viewers of this program. Thank you for inviting me to speak. Indeed, we are one of the highest burden country in terms of TB globally. It is true that with 54,000 people dying every year from TB in South Africa, it equates to 148 people dying every day. So it is bad, and we really want to fix that. However, I need to say that we made significant improvement in terms of incidence reduction. The theme of the conference has been really to accelerate progress to end TB. And in ending TB, we need to do three major things. Number one, bring down the incidence. Number two, reduce death rate to zero. And number three, ensure that people do not undergo catastrophic cost as a result of TB disease. So those are the three major things that we have to do. We've reduced incidence by 53% between 2015 to 2022. However, we haven't reduced death much, been only 17% reduction. We're aiming really much bigger than that. And 56% of people in South Africa spend more than at least 20% of their annual income because of TB, the TB disease. So those are, that's in a nutshell the picture of TB in South Africa.
And congratulations, I suppose, you know, inside the story of suffering in many cases on that reduction of the incidence of TB. That's quite a significant number that you've managed to achieve. Let's go back to the basics, Prof. When you think about the big picture and just how it is affecting our society and hollowing out families and homes of their breadwinners and just your loved ones in general, the TB itself is preventable. TB itself is curable and treatable. So I'd love for us to maybe share and home in on that message for South Africans right now.
Yeah, TB is curable disease. It is preventable. We're not doing very well at preventing, and that is why we are still having huge numbers. Of course, there's reduction, but we'd like to reduce even more. We need to do better with this. So it is really a challenge. But I think the response to TB has been essentially biomedical over the years. We've done a lot in terms of providing treatment, good treatment, particularly with drug-resistant tuberculosis. But the other aspect, non-clinical aspects, have been really a major challenge. And for example, reduction of poverty, for example, just to give people nutritional support, psychosocial support. Those are important, as important as the pills or the medication. But I think we've done very well in new laboratory diagnostic, providing tablets, but probably we need to double our effort on the non-clinical interventions.
I want to go back, as you say, part of what fuels, for example, the bigger problems you experience later on is on drug-resistant tuberculosis and so on, is sending out that very basic message to society. What constitutes the point at which, you know, you should worry about a cough and go and seek treatment? And then talk to us within the treatment centers across the country, what the experience of people is likely to be when they go and get help.
Yeah, so regarding cough, thank you for this very important question. The question of cough is an important one. Anybody coughing really should be careful, should test. Particularly when it goes beyond like a week or so. I know traditionally we said 2 weeks, but I don't think you need to wait for 2 weeks. But the major issue, and this came clearly through the conference, has been that many people, probably half of the people who have TB, are not coughing, are not having any symptoms. So that is really a big problem. People who are contact of those who have been having TB, or have been told to have TB, should be tested, even if they're not coughing. I think those are some of the things that we need to be doing. We're supposed to be doing that, but because this information is new, a lot of people are not really doing that. But it's not just about cough. If you are contact of somebody who's been told to have a disease, you could have it even if you are not coughing. So it's very important to tell people that. But again, the question of those who take treatment, they have to finish treatment. Because when you don't finish treatment, you stop treatment as you wish, then you resume treatment, you allow yourself to develop resistance. And when you pass the disease to your loved ones who live with you, you're going to pass a resistant disease. And in fact, as it is now, at least 55, maybe 60% of our multi-drug resistant TB in South Africa are people who never had TB before. They get it first time around. So it shows that transmission is high because we don't take all the precautions. That is why it's important that those who don't cough, but they have the contacts of people who are known to be TB should be tested regardless of symptoms. But even those who have finished treatment, even if they're told they're cured 6 months after and a year later, they should be checked again to make sure they haven't relapsed, they don't have TB again. Yeah.
Really important public service advice and awareness there that you're sharing with us, Prof Njeka. So, you know, it's difficult then, as you say, the presentation could be overt and you could have this cough undiagnosed for a week or continuing beyond a week, go and get yourself checked. But you could also have it without portraying the sort of traditional symptoms or a cough. So go and get tested. Talk to us now about the testing process and the sputum test that happens so that people who are worried that it might be an invasive thing to determine whether or not they have it can have their fears allayed.
So in terms of testing, we do what we call TB-NAT. We call them TB-NAT tests. We used to do GeneXpert. We brought in 2 other types of tests. They are molecular rapid tests. You just need to give your sputum. So it's very simple, very easy. You give your sputum at a clinic. It gets sent to laboratory, and within a day, you could get your result. The test lasts 2 hours in the laboratory, but because of logistics, you might find that these laboratories are not at every facility. So they will send a sample to a lab, nearest laboratory. You should be able to get your result within a day or 2. And if you have TB, you need to start treatment. So it's not really invasive. You just cough, sputum, you give in a small bottle. That's it. It's very simple.
I want to talk next, Prof, about pediatric TB. We often talk about adults and the care, of adults, but this is a big issue as well when it comes to treating, TB in children and adolescents, but also in preventing TB infections in this demographic. Share some more information with us.
Yeah, regarding pediatric TB, it's very difficult to make a diagnosis, particularly because children have what we call in medical language paucibacillary disease. They're very small quantity of agents, of microbes when they cough out and all that. So it's difficult to diagnose. Unlike in adults where you have a lot of you get millions of microbes in the little amount of sputum you can see when you test. With children, paucibacillary disease is a big problem, but also the little ones, less than 5 years, they have a tendency to not to cough out. They take everything in. They swallow everything, so it becomes difficult. We do collect the gastric fluid to test, but it's not good enough because there's acid that will really deal with some of those microbes. We also use stools sometimes to test. It's very complicated. We need experienced physicians or pediatricians to take care of this, but we're making effort. I know stools test is not yet done everywhere, but there are a few pilot sites in the country. We're hoping that in future there will be more of that, but also going to decentralize more diagnostics by training people at primary healthcare sites how to collect gastric aspirates and do all this. But again, in children, the lab usually doesn't give the results, but you need to take history, look at how is the growth, whether the parents are also sick or the caregivers and all that. So it's really very difficult, but we want to make efforts to increase the number of children who have tuberculosis among all TB patients in the country.
Prof, how affordable and accessible are testing and treatment, especially at primary healthcare level and in terms of what's freely available to the public?
Treatment is free. Diagnostic is also free. All our primary healthcare clinics, 3,700 of them, approximately, are able to collect a sample and send it to our National Health Laboratory Services, and you get diagnosis. Any hospital can also do the same. So it's free, and I encourage people to get tested free of charge and get treatment also. It is free of charge.
Anything else, Prof, that you want to share with the public? Again, as you said right at the very beginning, despite the fact that, we have made improvements in the reduction of incidence in TB, I think the number you shared with us was around 53%. We haven't been doing as well when it comes to reducing the number of deaths through TB in South Africa. And I imagine that's also connected to some of the comorbidities that people might have. So just talk to us then about that area of difficulty in trying to make severe or serious inroads in preventing people from ultimately succumbing to this disease.
Yeah, so thanks a lot. That's really very important. We are waiting, I would say impatiently, a TB vaccine. I think a vaccine is really what will help us go through the last phase of the fight against tuberculosis, can help prevent the disease, because while the global community, for example, gets 10 million people with TB per year, and with us is like approximately 280,000 a year, we know that the number of people with latent tuberculosis is bigger. you're looking at probably 2 billion and all that. So now when you have a vaccine, you give it to high-risk groups, and you scale up in population, you can really bring down the incidence of tuberculosis. But in the meantime, we need to continue efforts to find those with TB and link them to care, and make sure they are retained in care, because one of our major challenge, which could explain partially the high death rate, is that our people don't stay on treatment. We have, for example, among the MDR TB, 17% that stop treatment, they don't finish. For drug-susceptible TB, up to 7%, 8%, 10% is a big number. We really need to make sure that people are supported to finish treatment. But in order to do that, we need to strengthen our support, psychosocial support, nutritional support. And we now have a multi-sectoral accountability framework in South Africa. So we need to put that to work so that we ensure that all state departments, do more, same as Department of Health, because Department of Health alone cannot win the fight against tuberculosis. TB is more of a social disease than a medical disease.
Very important. And maybe then to close, which I think would be appropriate, is to talk about the launch of the My TB Story platform. This is where you're trying to get engagement between, those with an experience in TB, those who, are working in our communities, as well as health officials. So maybe just to close, a final word about the My TB Story platform and how our viewers and their families can get involved.
Yeah, so the My TB Story is an exciting development within TB, and it comes by us really realizing that communication is key to reach our goals. We neglected that for a long time. We've been very biomedical, so we really want to be intentional about talking to people, giving them a platform to communicate, and we also thinking that will help us establish what the TB ambassadors. In the long run, we're going to have vibrant TB ambassadors, not necessarily just celebrities, but people who have gone through the disease, who've gone through that experience of living with TB, and we believe that will help us break stigma, because stigma is a key challenge, and we're really going to get many more benefit. So we look forward to the fruit of the My TB Story, and I hope people will participate, everyone, civil society, all ordinary people, and we'll get a lot of TB champions out of that. Some prefer to be called TB warriors.
All right, well, thank you so much. I think we've done an important service to the public today in sharing the message around TB, staying on treatment, and making sure that we don't develop, the disease to a point with the neglect of treatment where we cannot treat it because the drugs then that we would need to innovate and create may not be on time or available. So get diagnosed, stay on treatment, and, take care of those around you. Professor Norbet Njeka is the head of the TB program in the Department of Health. We appreciate your time today.